Allison, the family just got here. We made a mistake. I have no idea what to tell them.
Calm down, it'll be okay. The patient is doing well now. We just need to tell them exactly what happened. So, can you tell me where you think things went wrong?
Yeah, so I noticed the patient, he was taking some benzos and some opiates at home for his pain medications. And then he came in with pneumonia. We gave him additional narcotics, and that caused him to become overly sedated.
I agree with you, and that's why when I came in, I gave him Narcan to reverse that reaction. And after that, the patient's respiratory status improved and he became stable. So I think what we need to do is tell the family exactly what happened. Do you have any questions or concerns about going in and talking with the family?
So do we admit that we made a mistake?
Absolutely. I think we talk to them exactly what happened. We first want to start with asking them what their understanding is so that we know where to start. And then from there, after we've gauged their understanding, we can talk with them about this patient came in with pneumonia. He was given additional narcotics on what he was already using at home, and the combination of those narcotics caused him to have some respiratory distress. At that time, a code was called, and we responded, gave him the appropriate medications, and he responded well and improved. Any questions?
No, I think that makes sense. I've never actually done this before, so if you don't mind, would you mind accompanying me to talk to the family?
Absolutely. I'll be at your side, and if there's any questions or concerns the family has and you don't know the answer, I will be happy to jump in and help you out.
Sounds great. Thanks. Hi, Mr. Jones. My name is Dr. Usselman. This is my colleague, Dr. Early.
Hi, Dr.
We're
Early.
taking care of your father. If you don't mind, let's have a seat and talk
Sure.
some more. So what's your understanding of your father's condition?
Well, he was brought into the ER. He had pneumonia. Once he was brought into the ER, then he was sent up to the ICU. But from what I understand from there, I was actually in the waiting room, when I heard this code blue thing come over, and I was going back to see him. The nurse told me I couldn't go back to see him because the code blue was being called to his room. My understanding is that code blue is some type of distress or possible CPR needs to happen or something like that. So from there, I have no idea what happened to him.
Okay, so let me explain to you what happened. So initially your father came in with pneumonia and he was in a great deal of pain. So we ordered narcotics for him, which are pain medications to help alleviate his pain. Once after he received those medications, he became overly sedated. And upon reviewing his chart, his past medications, it seems that he was already on some anxiety and pain medications at home.
Correct, he is.
So the combination of the medications that we gave him in the hospital and the ones he already at home caused him to become overly sedated.
But you said upon reviewing his chart, when did that happen?
That happened after you received the medications.
So you ordered the medications and then reviewed his chart?
Correct. A mistake was made on our part, and we apologize. However, we have taken the necessary measures to help fix this problem.
Well, how's he doing now? I mean, what's happening with him?
So what happened after he was overly sedated, we came and we gave him Narcan, which is a medication to help reverse the effects of opioid overdose.
Right.
After he received that medication, he regained consciousness, now doing fine. Does that help explain it a little bit?
It does, but what is a Narcan? What is that?
Narcan is a medication that essentially goes in and reverses the effects of too much pain medications.
So you're kind of saying like an antidote.
An antidote.
So how long does that last, and can you start to become sick again?
So the Narcan lasts for about 2 hours.
Okay.
If there is still some additional narcotics in his system at that time, he can become sedated again. The nurses know to watch for that, and if he's starting to have problems, we can always give an additional dose of Narcan until the narcotics are out of his system.
Okay. And you're saying he's doing fine now?
Yes.
Right, and I'm able to go see him?
Yes.
Well, I appreciate you, with your honesty. I'm very concerned that, reviewing charts after you give a medication like that, somebody really should have been looking at his chart. So I'm a little concerned at what's going on the floor at all times, with care of the patients.
anytime a situation like this happens, we always log it and note to review exactly what happened that caused the mistake, and so we can prevent it from happening again. In this situation, his medications were reviewed, but it was not reviewed exactly when he had taken those medications prior to coming to the hospital. And that's something that we need to be aware of here and in the future. If there's any other questions or concerns you have, you're more than welcome to talk with your nurses. They always know how to get a hold of us. Or you can also call us, and here's my card in case you need to talk with me again.
All right. Well, I really would like to go see him.
Okay.
Absolutely. We can bring you to go see your father. Any questions or concerns for us now?
Not at this time.
Okay.
All right.
Once again, we apologize for the mistake, and we assure you will provide the best care for your father.
All right. Thank you.
Hi, Mrs. O'Brien.
Hi.
Hi, how are you doing today?
I don't feel good.
Not doing too
I
well?
don't think I've healed up yet. I'm
Okay.
very sore.
Okay.
Very
So
sore.
that's actually why I came to talk to you today. As you know, you've been through a major surgery when you had that laceration of your spleen. You went into the operating room, and actually the surgery went successfully. They took out your spleen, and we thought that everything was going to progress well after that. But when you continued to have this abdominal pain afterwards that wouldn't go away, we started to suspect that maybe there's something else going on. So what we did was we ordered a CAT scan of your belly to take a look and see if there was anything going on. And we actually did find a reason for your pain. So what I did was went ahead and called the surgeon, and I actually brought one of the surgeons here that was in on your case to explain to you what happened and why you're still having that pain. Okay? And they're actually...
Hi, Mrs. O'Brien.
Hello.
Nice to see you again. I'm Dr. Krebs. I'm the surgical resident, one of them who was in the case. And I understand that you're still having some belly pain.
Oh, yeah.
So whenever your internal medicine doctor ordered the additional imaging of your belly, we unfortunately discovered that there is still a sponge left inside after the surgery.
Inside me?
Yes, inside you. So the surgery went really well. We were able to remove your spleen, but because it was such an emergent situation and an emergent surgery, we often use gauze to help with the bleeding during the procedure. And whenever we closed you up, although the counts, we always count every piece of gauze that we put into the surgical area, and then count the gauzes when we take them out so that we make sure that they match. So somehow the gauze count was off, although it was noted to be normal in the books. So when we sewed you up, we thought that all of the gauze was out. And unfortunately, with your continued pain and the extra imaging, we see that there was one that was left in.
So what are we going to do?
Unfortunately, we're going to have to go back in and surgically remove that.
I have to have surgery again?
Yes. I know it's very distressing. I understand.
Will I have to pay for this?
No, actually, from my understanding, the hospital goes ahead and waives the fee for this because it wasn't your fault.
No.
No, not at all. So I'm very sorry about this.
Oh.
What questions do you have?
When will this happen? We have to do this right away.
Okay, we can definitely schedule that. I will talk to the attending physician, and we will get you on the schedule as soon as possible, whatever works with your schedule. And until then, we'll make sure to control this pain you've been having so that, you know, you can make it to the surgery, and hopefully after that surgery, then your stomach pain will be gone.
Okay.
Okay. Well, if you have any other questions, please feel free to call our office, but I will go ahead and talk to the surgical attending and see when we can get you on the schedule.
Okay, so we got this patient in room 537, 50-year-old dude, came in, complained about chest pain, had some nausea, vomiting. He said he smokes, and his father had a heart attack at 48. His troponins were positive. He did have some EKG changes. We got a cardiology consult and ordered some follow-up labs in the morning. And if he worsens, I guess we could just transfer him to CCU. I think that's about it. You have any questions? Or?
Not really. I'm getting paged by the ER. Looks like I got 3 to see already, so I'm gonna go.
Okay.
Tell me what's happening tonight.
All right, so we got this 50-year-old Caucasian male. He presented to the ED with chest pain that radiated his left arm, accompanied with nausea, vomiting, diaphoresis. It started while he was shoveling snow, and the longer he was out there, it started getting worse. Past medical history is consistent for a 30-pack year smoking history, family history of early heart attack. His dad died at 48 from a heart attack. He has diet control, type 2 diabetes, hypertension, and hyperlipidemia. His first troponin that we got was indeterminate at 0.04, and he had also EKG changes that showed nonspecific T-wave changes with no ST elevation and no prior EKG for comparison. He was given a round of 3 nitro, then nitro paste, oxygen, and aspirin with relief of chest pain. He was loaded with aspirin in the ER. He was admitted to telemetry with nitro paste, metoprolol at 25, and titrating up, tolerated by his heart rate. Aspirin, atorvastatin, oxygen, and morphine PRN for pain. He is not on ACE inhibitor because he has an allergic reaction to it. He gets angioedema. Overnight, he is to be on telemetry. Cardiac enzymes are cycling. Cardiology is consulted, and he has MPO for possible cardiac cath. There is lipid panel, hemoglobin A1C, and EKG pending for the morning. He's confirmed full code. If he has any escalating chest pain, hypertension, or arrhythmia, he should be transferred to the CCU. Can you please summarize the key points that you heard from me?
Yeah, definitely. It looks like we have a gentleman who's coming in with potential NSTEMI, and overnight I'll be just watching his troponins as they come through and transferring to the CCU if anything happens in terms of hemodynamic instability and if the troponins keep rising.
Excellent, exactly.